happy to see all of you here. This is our second year partnering to present this conference, and this year we have at least twice the amount of participants as last year. So we'd like to see that as evidence that our momentum is increasing and the community is coming together more to support mental health in Hawaii. So let's give ourselves a hand for this great turnout today. So please continue to enjoy the healthy buffet throughout the morning. Don't hesitate to get up at any point if you need to stretch your legs. Restrooms are outside and against that wall. Please put your phones on silent and join me in welcoming NAMI Hawaii President Mike Durant.
Hi, good morning everyone, and thank you for coming to our Healthy Living for Mental Wellness. This, again, is our fourth annual conference that NAMI Hawaii has been holding. That's one of our goals every year, is to hold an annual conference. Again, as Tricia said, we have more than twice as many as last year, so it's building. We pretty appreciate it. Thank you so much for coming. And this is the second year we have partnered with Mental Health America and this thing, and we really appreciate the working with them. I just wanted to introduce a couple of people who are not on the program but are important to us. And Dr. James Westfall, who was recently with the Adult Mental Health Division but is now with Beacon Health Services. Jim, there, over there. Thank you. Bud Bowles, Executive Director of the United Self-Help, which is providing support and education for people with dealing with mental illness. And I kind of think of United Self-Help. There he is. United Self-Help is kind of the third leg of the stool of the people who, the organizations, Mental Health America, NAMI, and United Self-Help, who are dealing with support and education with people dealing with mental illness. Is Bonnie Madigan here? Don't know. Okay, Bonnie Madigan, who has been coming in the past, and she's the mother of Ben Snavely, who Ben passed away in November of 2015. He was a consumer, and contributions in his memory have helped fund these conferences. Ben was a friend of our son Jay, who was also passed away, but they both struggled with serious mental illness, and anyway, she's been very helpful to us. So that's all I have to say. So Tricia, you can have the stand again. Thank you.
Sorry. Thank you, Mike. We have a fantastic program for you today, inspired by what all of us at NAMI Hawaii and MHA Hawaii want to know more about ourselves. What can we do as individuals to keep ourselves healthy? How do we connect nutrition, exercise, technology, and other aspects of health to promote our overall well-being? Backed by popular demand, Paul Gionfriddo, President and CEO of Mental Health America, the national organization we are affiliated with, will deliver our keynote, Healthy Living for Mental Wellness. Paul's presentation will be followed by Q&A. The cards on your table are for you to submit your questions on. So during his presentation, please write any questions you have on those cards, which we will collect. So let me tell you a little about Paul. In addition to leading Mental Health America, Paul has been a consultant, speaker, writer, and nonprofit leader in 3 states. He served as a full-time elected official for 13 years in the Connecticut State Legislature and is mayor of Middletown, Connecticut. In 2014, Paul published a book merging his professional and family experience with mental illness and mental health policy called Losing Tim: How Our Health and Education Systems Failed My Son with Schizophrenia. Welcome back, Paul.
Thank you, Tricia, and thank you all. I'm just going to double check here so I know my time for this morning again. I really appreciate the opportunity to come back and spend some time with you again this year. It was a real honor to come last year to be invited to do this particular meeting, and when Tricia contacted me a few months ago and said, would you be willing to come back? We'd like to have you back again to Hawaii. I really couldn't believe it. It's just a great honor for me and just a tremendous opportunity, I think, for us all to think about some of the things that we can do in the context of some of the things that our policymakers and our program leaders could do to enhance our health and well-being. The question that Mental Health America has posed an awful lot this year as we lead up to our annual conference in June, this coming June, is are we living in the past or are we fit for the future? And I want to talk a little bit about how we came up with that particular theme and what it means to us. While I'm going to focus a lot on personal fitness as one of the 4 elements of our Fit for the Future theme, I also can't do any kind of presentation, as people know who know me well, without talking about the policy context and the program context around supporting people's own personal health and mental well-being. So I'm going to talk about those things as well in the course of this conversation this morning as we focus in on what it means to engage in healthy living for mental wellness. Now, let me start again by just reviewing Mental Health America's mission, because it fits closely with the theme of this morning's talk, and it also fits closely with the theme that we have for our annual conference this year. Mental Health America was founded back in 1909, and it is the nation's oldest advocacy organization, period, in this space, but certainly the oldest advocacy organization that focuses primarily on mental health. We believe in prevention for all, early identification and intervention for those at risk, integrated health, behavioral health, and other services for those who need them, with recovery as the goal. And that's the elevator speech that, as those of you who were here last year know, we collapse into our hashtag before stage 4, which really speaks to the idea that we have, in the course of our lifetimes, treated mental health conditions differently from the way we've treated every other chronic health condition in America. We've treated them as public safety concerns, where a trigger to treatment, services, and support is danger to self or others, a non-clinical standard that has meant that mental illnesses and mental health concerns become the only chronic diseases in America that we wait until stage 4 to treat, and then often inappropriately only through incarceration. And when I talk about mental illness and I talk about the need for treatment, comprehensive services for people and on behalf of people who have serious mental illnesses that move people along pathways to recovery, I also often talk about how important it is that we do our work as early in the process as we can. Because we haven't bent the curve with cancers, we haven't bent the curve with heart diseases, we haven't bent the curve with diabetes and the deaths that result from them by intervening better at stage 4. We've bent the curve by intervening better at stage 1. We've bent the curve by doing a better job around promotion of prevention, better job around promotion of wellness, better job about promotion of early identification and early intervention, and a much better job of putting our resources at those earliest stages so that we can keep people on pathways to health as well as mental health. So that's what we've been trying to do at Mental Health America, and believe it or not, we've been trying to do this for nearly 110 years now. When Mental Health America was first formed, we tend to think about the fact that that was a very different time and in a very different place. where we relied so heavily on institutions to provide services for people with mental health concerns, often mild mental health concerns as well as serious mental illnesses. But in fact, back in those days when Clifford Beers, our founder, formed this organization, he said we needed to focus in on our kids. And we needed to focus in on screening, widespread screening for kids and adults. We needed to focus in on the earliest possible stages of a disease process, or else we were going to continue to consign individuals to mental health institutions, and even worse, our jails and prisons. Well, look at us a century later. We have, in an effort to try to move people from mental health institutions, state psychiatric hospitals have effectively moved them into the same kinds of programs that we now simply call county jails and state prisons. Again, a function of treating this as a public safety issue, not a public health issue. So let's talk more about health, and let's talk about mental health and mental well-being. This year, we have just released our Mental Health Month Toolkit. And Mental Health Month, which is celebrated ubiquitously during the month of May, is Mental Health America's oldest mental health awareness opportunity and engagement activity that we've had. It started in 1949. Actually as a mental health week, and became Mental Health Month when President Eisenhower first proclaimed that back in 1953. And as a result of that, every single year, thousands of organizations pull together during the month of May in informing people about mental health and well-being. We at Mental Health America appreciate particularly the efforts of NAMI and NAMI affiliates to call attention to Mental Health Month. We like to return that favor during Mental Illness Awareness Week during the month of October, which really is headlined and promoted by NAMI affiliates and NAMI chapters all around the country. So you engage with us during the spring, we engage with you in the fall. We do it at a local and a national level, and between us, we have increased awareness about both mental health and about recovery from mental illness. This year, we're talking about both the brain and the body. In consolidation or in conformity with our theme of our annual conference, Fit for the Future this year, we are, during the month of May, focusing in on something that we're calling, for mind and for body. And using that hashtag of being both about the brain and about the body, we think that we are going to be moving people to talking more about the whole individual, talking more about what we can do for people as a whole, because often the things that we can do to keep people physically healthy are the same kinds of things that we can do to keep people mentally healthy. And the things that we have done, frankly, to promote poor physical health, we've often done to promote poor mental health as well. Now, the 4 domains of fitness that I like to talk about are policy, programmatic, practice, and personal fitness. And while we're going to spend time on personal fitness right now, toward the latter part of this particular keynote, I'm going to talk more about those other domains as well. So let's talk about personal fitness and some of the issues that arise for people with serious mental health concerns and other people who are maybe in the earliest stages of feeling mental health concerns, of beginning the process of having mental illnesses. One of those concerns is co-occurrence. And we'll talk about the fact of co-occurrence between physical conditions and mental health conditions. We'll talk about the fact that poor mental health does equate to poor health overall, and that what we need for us is self-care and choices. Where the individual is concerned, individuals do not want to be told by other people what you should do. Individuals want to have the opportunity to know that they have choices and options about what they can do to benefit themselves and to take care of themselves. And my personal fitness story may well be different from your personal fitness story. There's somebody I like to talk about at this particular instance. I don't know how many people in this room remember Jacqueline, right? We've got a group of people here. Many organizations, many groups that I talk to have all those people who are under the age of 40. They have no idea who I'm talking about. But when I was a kid, my mother every single day used to exercise with Jack LaLanne on TV, as many housewives in those days did. Jack LaLanne lived well into his 90s, only died a few years ago, as a fitness expert. And one time in his 90s, he was talking with somebody, an interviewer, and the interviewer said, well, how do you keep yourself so healthy? And Jack LaLanne said, well, I work out 2 hours a day. Every single morning I work out for 2 hours. And the person said, well, other people can't do that. And he said, no, you don't understand. This is what I do to keep myself healthy. You don't have to work out 2 hours every single day to keep yourself healthy. And it was a great way to think about the fact that when we talk about this, there's no one size fits all here. What we need to provide is opportunities for individuals to define their own health and well-being and to be able to move themselves along pathways to wellness. I often learned this when I was back in the legislature in the 1980s as well, talking about people and with people with developmental disabilities. When we used to talk about the fact that people who had severe disabilities, for people from the outside looking in, it looked like basically these were fates worse than death that certain people suffered as a result of this, until you asked them about the way they felt. And what they would tell us was, no, I have a high quality of life within my own perspective. So maybe from your perspective, it's not the quality of life you think you'd like to have, but it's a good quality life, and I can build a better life for myself. And this is a second lesson I've learned and brought with me to Mental Health America in my advocacy on behalf of people with mental health concerns with serious mental illnesses. The opportunity for self-care and choices being the critical opportunity along pathways to wellness and recovery. Well, as I mentioned last year, we do an online screening program, and I want to give you a little bit of information from that program to give you a sense about co-occurrence here. So now we've had about 3.1 million people have come online to take a screen, 3,000 people a day take a screen, and we ask them about themselves after they take one of these 9 screens that we now have up there, 9 evidence-based screens. The typical screens that clinicians would use. They're the ones, the most common screens in use in America for mental health, like the PHQ-9 for depression, 9 questions, or the 7 questions in the GAD-7 for anxiety. So we have 9 of them, but rather than focusing in on that, I just wanted to focus in on a little bit about what our screeners look like, particularly those who have chronic health problems other than mental health problems. So our screening population is 3/4 female, about 2/3 under the age of 25, about 3/4 get a positive result. But here's the interesting thing. People who say they have another chronic health problem, we ask them about cancer, we ask them about heart disease, lung disease, chronic pain, dementia. Almost 80% of those people also screen as positive for a mental health condition. What it suggests about personal health and personal wellness is we can't separate the brain from the body in this instance. We can't separate an individual's mind from the rest of what's going on in their physical existence and physical reality. If we're looking for wellness around mental health, we've got to be looking for wellness around physical health too. And flipping that picture a little bit, if we're looking to bring people along a pathway to a healthier life and healthier living, we can't just address either the mind or the body. We can't just look at diabetes or mental illness. We can't just look at heart disease or cancer. We've got to look at individuals as a whole, and we've got to give people opportunities to get well and be well within the context of whatever chronic conditions they may happen to have. So, as I've mentioned, people who have chronic conditions who are positive for a mental illness, across all of these, the numbers are 79%, 78%, 78%, 79%, 74%. Across all of these, what we have learned is these things don't occur in isolation. They occur together, these kinds of conditions. So poor mental health often equates to poor health. That some of the problems that we see, particularly with people with mental health concerns, particularly with people with serious mental illnesses, 36.5% of people with serious mental illnesses report current use of tobacco. The 25% of people, up to 25% of people who have a mental health concern in any given year, that group consumes almost half of all cigarettes. And 80% of people with SMI, serious mental illnesses, are overweight or obese, fit into that category. So why is it that for so long, so many of our so-called treatment programs for people with serious mental illnesses gave people cigarettes to live on, said it was okay to be smoking here, and it's okay to promote smoking. Even in our drop-in centers today, even in our support centers today, people are often allowed to smoke outside the back of the program, outside the back of the institution, out in the parking lots and the alleyways, because we simply accept that it's okay for people to smoke if people have got a serious mental illness, because somehow this is going to make people feel better. You know, that's not what our screening population is telling us, right? Our screening population is telling us, no, now I've got COPD. No, now I've got heart disease. No, now I've got other kinds of lung problems or cancers that have developed. I don't feel better having smoked this way. In other words, what we need to provide are the same opportunities and the same promotion of healthy lifestyle, healthy living as we possibly can. The challenges we've got are poor diet. Not here. We have a great opportunity for a healthy diet here this morning. Egg whites only, not even the yolks, and lots of spicy, good spicy stuff that you can put on that stuff. We need to be able to talk about the importance of diet, because so many times the side effects of medications are weight gain. And if side effects are going to be weight gain, we need to make certain that people are not over-sugaring themselves. We need to make certain that people are having opportunities to be well and to be healthy. Too little exercise is another problem. You give people cigarettes to smoke, that's not enough exercise every single day to bring the cigarette up to here. It's just not enough, right? You got to put the cigarette down. That's a little better exercise. Do this act. But then you got to be able to get up and you got to be able to walk around. You don't need to be able to work out at the age of 93 for 2 hours every single morning lifting heavy weights. But we do need to be able to figure out whether it's that mile we're going to walk or those 3 miles we're going to run, or even that Ironman triathlon that some people will run. We need to be able to figure out what it is that will allow people to use exercise to promote not just their physical health, but to get the endorphin release and to do some other things that promotes their mental health and well-being too. I once was interviewing somebody back when I was in Austin, Texas, to work for the nonprofit that I had there, and she looked like a very good candidate. And I noted that, like me, she was a runner. And I was talking to one of her references, and I said, okay, what does this young woman do, basically, when she's in a stressful situation, particularly a stressful situation at work? And her reference said, well, she runs. And I said, well, she's a marathon runner. And the person said, well, she's under a lot of stress. So the idea is that we can use exercise, we can use healthy living to be able to counter the effects of really bad policies, bad programs, and otherwise bad practices. What we need to provide to people are choices and self-help. This is the word cloud from our mental health screening program. It's just us, everybody, not just those people with chronic physical health problems as well, but everybody who takes a screen. What are you looking for? And people are generally looking for help. You know, and here's a big deal about American society these days. We often value the individual, right? And how important it is for the individual to get ahead in life. How important it is that it doesn't matter if individuals step on other individuals to get there. You know, that anybody, you know, can realize the American dream by picking them up by their own bootstraps and making certain that that happens. That's all false. It's all fake news. I hear a lot about fake news in Washington when I'm there. And that's fake news, that people can get by, individuals can get by on their own. Repeatedly, individuals not only want to take care of themselves, but in order to take care of themselves, tell us also that they need help. And we need to be able to provide the kind of help that people need. They need help in 4 domains. That's what they tell us. They want to learn more about what they can do, about their condition, about what it is if they got a mental health condition, that it means for them. If it's affecting their sleep, if it's affecting their eating, if it's affecting other parts of their life, their social interaction. They want help. They want referral to care. They want referral to services. They want referrals to treatments. But they also want do-it-yourself tools. People will take care of themselves if we give them the kinds of tools they need to take care of themselves during Mental Health Month. We give people a calendar, 31 days, where people can do something simple every single day just to take care of themselves. That's the most popular thing we provide during Mental Health Month for every single year that we've done this. That's been the most popular thing that we do, this mental wellness calendar during the month of May over the course of the last 50 plus years that we've been producing Mental Health Month materials. But people also want engagement. They want to connect with other people. They don't just want to be left on their own. They want the opportunity to get help from people, and they want the opportunity to be able to give help to people who may need that as well. How we get there at Mental Health America, simple little sidebar, because it's critically important right now, is through a new program that we have called Screening to Supports. After one of these 3,000 people take a mental health screen as of today, and as of the course of the last month, they get a fully customized result based on those interests that they've got, based on the screen that they took, based on the severity of the result that they got in each of those 4 domains. And they will get referrals, they will get information, they will get do-it-yourself tools, and they will get engagement with peers, because all of these things lead to healthier living. All of these things lead to recovery. All of these things lead to good results. Now, back in DC, and in a lot of the states right now, you know, the biggest thing that everybody's concerned about is the epidemic right now that we've got, particularly around opioids, but the epidemic we've got around drug use. And there's a lot of dollars that Congress has provided for people to fight and combat drug use, prescription drug abuse this way, and substance abuse in general. The problem that a lot of people aren't looking at when they look at that is that they're forgetting again the whole person. What I can tell people is, you know, there's a reason why people take opioids in the first place. You know, for many people who have had these prescribed, they've been prescribed because they are effective painkillers. If you try to take the painkiller away, but you don't take the pain away, you're not going to get a good result. And too much of public policy right now is talking about trying to take the painkiller away without taking the pain away at the same time. Now, that's specific to people like me who've got back problems and other people who've got serious pain, but it's a metaphor for the way we're addressing a lot of these problems as well. We can't just focus in on limiting people's choices of painkillers, right, without focusing in on what's causing the pain in the first place. And when we talk about health and wellness, and we're talking about physical health and well-being, and we're talking about mental health and mental well-being, we need to be remembering that we have to look at the origin of the pain. We've got to be able to deal with the origin of the problem if we're going to get people along pathways to recovery, instead of continuing moving people down pathways to greater sickness and greater lack of health. So, we've got to think about policy differently from the way a lot of policymakers have thought about it. We've got to promote whole health during our policy, and there's some tools that allow us to do it. The promotion of whole health is something that would implement the vision of Clifford Beers more than 100 years ago, and that would be ubiquitous mental health screening for everyone. Right, the U.S. Preventive Services Task Force recommends screening, mental health screening, for everybody over the age of 11. The American Academy of Pediatrics now recommends that everybody get those kinds of screens when they're kids, and yet it is still uncommon that we do widespread mental health screening. You know, it's not uncommon that we do widespread cancer screening, though. Why is it we're being treated differently again of people who have cancer? Why is it that we promote widespread cancer screening? There was as much stigma around cancer 30 and 40 years ago as there is around mental illnesses today, but we still said we've got to intervene at stage 1. We've got to do early identification. We need to do the same thing here. And there's a tool that the federal government has provided to Hawaii and every other state in the nation, and that is the implementation of the free care rule, where with the stroke of a pen, the state of Hawaii could say we are adding ubiquitous mental health screening to our Medicaid plan. And when we do mental health screening in every school according to our mental health plan, we can go bill the federal government and draw down the Medicaid dollars for every kid who is Medicaid eligible. That policy has been in place since 2014 in December, and not a single state has used that opportunity to implement ubiquitous mental health screening in the schools. Hawaii could be the first. In addition to that, good policy will integrate education and health. So many of the people who take our screening are kids. So many of the people, we know this, half of mental illnesses begin by the age of 14, 3/4 by the age of 25. All we really need to do is to be able to think collectively, together, about not only what's going on in those kids' lives in terms of their health and well-being, but in their educational system as well. Too many of our kids get suspended or expelled from school. Too many of our kids begin pathways to isolation, not just because of their self-isolating behavior, but because the political policies and practices that are in place move them toward an isolated environment, either in schools or in the workplace, frequently then onto the streets and into the jails later on. It's the wrong way to approach a whole person. Workplace mental health is enhanced as a matter of public policy, and we need to be removing barriers to integration of health and behavioral health. Now, here's the biggest barrier, in my mind, to the integration of health and behavioral health. And it's almost a drinking game at Mental Health America when I say the words 42 CFR Part 2. Because every single one of my staff people knows 42 CFR Part 2. It's like for us, this thing that we all just get and we all just understand. Now, how many people here are familiar with 42 CFR Part 2? See, there's a little group here that's familiar, so I'm going to bring the rest of you up to speed about this. Okay? This is a rule, really important rule, that is the biggest single barrier to the integration of health and behavioral health. From 1970. It was put into place back before we had an Americans with Disabilities Act. Back when you could be fired for being drunk, basically. And what they said was, you can't do that in 42 CFR. But then later on, we passed the Americans with Disabilities Act, and later on, we passed HIPAA and provided new rules and guidelines for the sharing of information, but we never fixed 42 CFR Part 2. So today, if you want your health record shared between one provider and another provider, I don't know how many of you have tried to do that. It's really hard to do that. Even when you sign an authorization, sign a release, that's just to get your health information over there. But now you've got to make certain, if you want to get your mental health information over there, that you sign, and there are certain state rules around that too. Okay. But if you want the substance use information also included, then you've got to sign a different kind of a release under a different set of rules. And most providers aren't equipped to be able to take these things easily. So what ends up happening is you end up trying to treat a whole person with just half a record. And I have seen the results in programs that I've operated, particularly in the city of Austin, when people were trying to treat whole people with half a record, when they only knew about the health conditions and didn't know about the behavioral health conditions, because that information couldn't be shared because of 42 CFR Part 2. What ends up happening is you often get a surprise. The person you thought you were treating doesn't look anything like that person actually looks in real life. And as a result, bad things happen. You get bad outcomes with people, and you haven't succeeded in integrating health and behavioral health in this instance. And that's what we need to be focused in on doing, because we can't talk